Hey, good morning, everyone. Welcome to the Access California Quarterly Training. Thank you so much for being here today. I know coming in after a holiday weekend, it can be a really busy week, so we really appreciate you guys for making the time to be with us today. This quarterly training is titled Elevating Peers, Addressing the Missing SUD Lens in California's Certification Pathway. And my slides aren't advancing. There we go. So my name's Jocelyn Farrell. I am the program coordinator for Access California. Also on this call from our team, we have Nicole Chilton, our program manager, and Grace Gallagher, our education coordinator. And then leading our training today, we're just really blessed and privileged to have Carolina Ayala with us. She is the founder and executive director of the Happier Life Project. They are a partner of ours at Cal Voices, and we're always just really grateful to get to work with them and for every interaction we have to learn from them and to learn just from the wealth of knowledge that Carolina always brings to us. The mission of the Happier Life Project is to provide community support for people and families impacted by substance use disorders and mental health challenges through education, advocacy, and peer-based recovery support services with the intent to normalize recovery. So again, we're just really grateful for Carolina and for her agency and for them being here today to deliver this training for us. Just some housekeeping to begin. This training is scheduled for 2 hours. It will be recorded and posted on YouTube within a couple of days, along with the slide deck. If you'd like to speak at any point, raise your hand, and then at an appropriate time, we will unmute you. You're welcome to add your comments to the chat box at any time as well. We are also going to launch a demographic poll in just a few minutes, and that's just kind of to gather information like what county you come from and things like that. Some ground rules to begin. We just ask that you honor yourself and practice self-care. So if you need to get up, step away for a minute, that's totally fine. Model the behaviors that you'd like to see in others and honor your fellow attendees. And that would mean assuming good intent in others, focusing on the issues and the facts rather than on individuals. Look for areas of alignment, even if you disagree with something that's being shared, either by the presenter or other participants. And if you do disagree, again, that's totally fine, but we ask that you disagree respectfully and try to stay solution-oriented. And then as you share, we do have a number of people on the call. We've got about 40 people here today. So we just ask that you keep your questions and your comments brief so we can hear as many people as possible. If you have any other ground rules that you think would be helpful for us, you're welcome to drop those in the chat box right now. And with that, I will pass this over to Carolina and launch the demographic poll for you.
Hey everybody, good morning, Grand Rising. Hope everybody had a good holiday. Thank you so much for the introduction. I'm going to share my screen here. Can you see my screen?
Yep, perfect.
Should I fill out the demographic form as well? Do you want me to do that?
I'll keep that up for about a minute longer and then I'll close it down. But you're welcome to begin while people are filling that out.
Okay, I was filling it out too, sorry about that. Okay, make sure I have everything here. Good morning, everybody. My name is Carolina Ayala. I'm founder and CEO of the Happier Life Project, and I am working with two screens, so bear with me as I may be shifting in between and may not be looking at the camera the entire time. Bear with me. Let's see. There we go. And so again, Carolina Ayala, founder and CEO of the Happier Life Project. And what I want to do is I want to begin by acknowledging how I come to this work. And that is through the lived experience of recovery and through community organizing and a deep and abiding love for the people in our systems that so often get forgotten. And that's the people who use substances, who are surviving on the sidelines, who are dying at rates we can no longer accept. So today, what we're going to do is speak some uncomfortable truths. You know, California has built a peer certification system, and that's a monumental achievement, but we built it without a specialization for the population most at risk of overdose, most subjected to stigma, and harmed by our fragmented systems, and that's people who use substances. So today, we're here to talk about that gap, and we're going to position peers at the absolute center of the BHSA implementation, the BH Connect infrastructure, CalAIM transformation, and the $4.5 billion in opioid settlement funding that is sitting in county coffers right now. So this is not theoretical, this is life and death. And so I'm really excited that I get to speak on this, as it's been something for probably about 3 years. You know, the Happier Life Project, I was born in 2021. And at that point, after we had the certification and the training that came out in the 80 hours, I had brought it up that it was from my interpretation and understanding from having taken several trainings, that there was a heavy focus on mental health and a lack of substance use education in the way that we work with people at THLP as a recovery community organization. So everything that I'm sharing is from my perspective. There are some things that I've come to understand that are different in different counties. And so I just want to start with that not every county operates the same. We are in Riverside County. It's very different in LA, different in Lake County. So just want you to keep in mind on some of that when I share about some things that come up that may not apply to the county that you're in. So let's see. So before we dive into the policy and the data, if you wouldn't mind for us to ground together, to hold space for anybody that's gone through grief. We just had the holidays, for any loss, any anger, and also for hope. And I'd like to start with taking a slow breath together, if you're okay with that. Deep breath in.
Hey, Carolina.
Yes.
Sorry. People are in the chat are having a hard time hearing. It doesn't sound echoey to me, but it sounds like it's echoey for other people. I'm not sure how we should fix that. Sorry.
That's okay.
It might be the room.
I haven't had that challenge. Maybe it's the headset. Okay, go.
It sounds fine for me.
Does it?
Yeah, it sounds fine for me too.
Maybe it's not.
Whatever you did, it just got better.
It did? Okay. Okay, great. Thank you so much, David.
Thank you.
All right. So yeah, if we could just take a deep breath, everybody, in through your nose, out through your mouth. If you're comfortable doing this together, please. So I know that we talked on some agreements, and thank you for that about this session, but I'd like to go over some also. You know, many of us in this room have been deeply impacted by substance use, our own or that of people we love. And the experience is expertise, you know, and so I want to honor that. Also, you know, we will have points in time for people to ask questions, as well as in the end, just kindly ask, you know, to speak from share your story, your perspective. You are the authority on your own experience. Third, you know, honor grief and loss. We have all lost people, or many of us have lost people to overdose, to incarceration, to a system that was not built to hold them, and we carry those names with us. Also, as was mentioned earlier, thank you, stay solutions focused. So we will name problems clearly, but we're here to build something different, not just critique. And let's continue with open hearts. So here's where we're going to go over the next 90 minutes. So first, we're going to look at SB 803, what it built, and critically what it missed. Second, we're going to expose the invisible people who use substances workforce, the peers who are doing the work right now without a specialized training, without recognition, without support. And third, oops, we'll do that. Third, we'll explore the major policy shifts happening around us, which is BHSA, BH Connect, CalAIM, and why they all assume a people who use substance peer workforce that doesn't yet exist. Fourth, we'll talk about money, specifically the 4.5 billion in the opioid settlement funds that are how peer roles are explicitly allowed, but not being funded because we lack infrastructure. Fifth, it will dive deep into what PWUS, which is people who use substances specialization, actually is the 9 domains, the training structure, and the competencies that we would like to propose. And then finally, we'll talk about mobilizing, how we turn this vision into reality, who needs to act, and what we can do starting tomorrow. So this is a full picture. It's going to show some gaps, the system shift, the funding, and the solution. And hopefully it's something that we can build together. I want to start with a story. This is a real story from California, though I've changed the name. Maria is 34 years old. She lives in Central Valley. And over 2 years, she went to the emergency department 17 times, mostly from overdose, sometimes from infections, sometimes because she had nowhere else to go. She was admitted to detox 4 times, and each time she was discharged with a list of phone numbers and no follow-up. No one to call, and not one call from anybody. Not one peer reaching out to say, hey, I've been there. Let me help you navigate what's next. She was also on probation, and she met with her probation officer every month. Never once was she connected to a peer with lived experience who could help her with accessing housing, benefits, or treatment that actually fit her life. She did not have any clinical diagnosis. 3 days after her last hospital discharge, Maria overdosed again. This time she survived, but no peer reached out afterward. No one from the overdose response team, no one from harm reduction. At every single touch point in Maria's journey, the emergency department, detox, probation, discharge, post-overdose, a peer could have changed that outcome, and a peer could have built trust, provided hope, navigated systems, and walked alongside her. But we don't have a people who use substances peer workforce that is trained, tracked, or funded to do that work. We're here today because the gap is real and it's harming people like Maria every single day. Now, I share that because at the Happier Life Project locally in our county, we have participation in what is called the Riverside Overdose Data to Action. And so we come together, a bunch of different agencies around the county and community-based organizations, and go over the overdoses that have happened through the month and in the different settings and the different places. And in that, we get to see all the different touch points that people had throughout the time of when they came across the system, across an agency, where there could have been somebody to intervene. And most often than not, there's all of these entry points where a peer could have actually been there to support that person, and there wasn't. So as highlighted, there was 22 ED visits in 1 year, 3 overdose reversals, 2 jail bookings, and 0 peer encounters. Now that's a problem. So let me give you the numbers because they're staggering. Did I miss this? Give me 1 second, please. So systems are shifting under us, right? So SB 803 in 2020 gave us the peer certification, and that was established. We got the BHSA 2023 and then BH Connect 2024 with the federal integration mandate. Now, this was historic, SB 803. It gave peers a billable role, it standardized training and legitimacy in the healthcare system. BHSA, it passed November 2024, I believe, and it required California to expand the SUD workforce, strengthen the crisis continuum, and align mental health and substance use systems. We got BH Connect. It's the federal initiative to build out the 988 crisis infrastructure with an explicit expectation that peers will be embedded into the SUD crisis pathways. There's also CalAIM. It's transforming Medi-Cal, emphasizing community-based services, whole person care, and non-clinical support, exactly what peers provide. And then there is the $4.5 billion in opioid settlement funds that California has received with explicit allowance for peer support roles. All of these policies are moving. All of them assume a robust workforce that works with people using substances, but that workforce doesn't exist in a structured, credential, certified, trackable way. That's the gap, and that's what I'd like to go into. So one thing I did learn prior to this presentation, as I spoke with another partner in one of the counties, is even though the state itself, like I pulled off of Cal Mesa, the numbers that would show how many certified peers we have, if we had any specifics under working in SUD facilities and Drug Medi-Cal ODS. There wasn't anything broken out in that. However, each county does have that within their own county. I just was unable to obviously get 58 different counties to give me their information to be able to have here to present. So I'm going off of what the state has provided, and there was nothing in there that I could find that showed that. I need a pause for 1 minute. Just give me 1 second. Sorry, everybody. And back. Thank you. All right. So my slides, I don't think are actually the order that I thought they were supposed to be. So I do apologize, but I'm going to go into the SB 803 and the current peer landscape. And we're going to talk about what it actually accomplished, because it was a huge win. And it created Medi-Cal's peer certification for the first time. Peers could be certified, credentialed, and providers under Medi-Cal. It standardized the training instead of dozens of different programs with different standards. California had an 80-hour foundational training with 17 core competencies. Now, I'm sure some of you know that the trainings are very different depending on where you take it. I'm not saying that there are not any of the 80-hour trainings that do highlight some of the core of working with somebody that's still using substances or harm reduction, because it's just not all across the board. It also allowed, activated billing codes, specifically, the H0038, which allows peers to bill Medi-Cal for peer support services. And it allowed peer support across multiple systems, which is mental health, substance use, criminal justice, child welfare, and even schools. So this was monumental. SB 803 legitimized the peer workforce. But, and this is critical, SB 803 did not create a specialization for people who use substances. The training is generalist. It's broad. It's primarily built around mental health recovery. And while that's valuable, it does not prepare peers for the overdose-driven polysubstance use, fentanyl-era realities of working with people who use substances. So the workforce remains generalist, and that is a problem that I think we can solve. Now, in speaking with DHCS also about this, the intention was, when this was created, that it did cover both mental health and substance use in an integrative way. So it wasn't something that was done, without thinking of the substance use community, according to DHCS and Cal Mesa. However, after the 3 years of seeing this, it has left it out. And I've spoken with people who are in recovery for their mental health, who have been in positions where they worked primarily with people in recovery with their mental health, and were switched or shifted in their role to work in substance use communities, or working with people going through harm reduction. And they've shared themselves that it was very challenging to them because they could not relate, they could not identify, nor could they help in the way that they felt that they could help somebody in recovery with their mental health. So I just wanted to highlight that it has come from the workforce itself, in stating that at times, right? So the foundation is solid. The competencies include things like recovery support and wellness, mentoring and education. The foundation is solid. The competencies include recovery support and wellness, mentoring and education, advocacy and empowerment, ethical boundaries and confidentiality, and cultural responsiveness. So these are essential, and every peer needs them. What we're proposing is adding a PWUS specialization, like an additional 30 to 40 hours of training that goes deep into the specific knowledge, skills, and ethical considerations needed to support people who use substances. So think of it like this. The 80-hour training is your bachelor's degree. The PWUS specialization is your master's degree in a specific population. So the foundation is solid. The specialization gives depth, protection, and preparation for the real-world context peers are being deployed into. Okay, there we go. All right, so 6,000 plus certified peers. I think we're at about 7,500 from the last report I saw, but I know that there was a big celebration when 6,000 plus was reached. So as of early 2024, California had over 6,000 peer support specialists through Cal Mesa, which is incredible. That is a workforce. The problem was that I could not find, again, the state and the documents that I got from Cal Mesa and the meetings that they had, where there was a database or a report on how many are working with people who use substances, who are employed in SUD treatment systems, serve overdose survivors, work in harm reduction programs, or are deployed in the emergency department or post-overdose response. We have no idea, or I couldn't find that. That data did not exist. The report from Cal Mesa in October did show how many peers that are certified have their own lived experience of recovery from substance use, but not where are we being positioned and where are we working throughout the state. So if we can't see a workforce, we can't strengthen it, we can't fund it, we can't support it, and we can't protect it. So this invisibility is not benign. It's harming peers and it's harming the people that we serve. And I believe that a PWS specialization, again, people who use substances, would solve this. It would create a trackable, reportable category of peers who are trained and credentialed to work with that population. And for the first time, California would be able to say, we have X number of PWS specialized peers here where they work. Here's the impact they're having. So there's also it highlighted how many are working with families or have the specialization of families, unhoused, and justice involved, which the numbers were very, very low, which was really alarming also. So what we don't know, we can't fund. So let me drill down to the invisibility problem. Because it's not just an inconvenience, it's a strategic failure. Here's a chain of consequence. So no data, we can't count PWS peers. No counting, we can't build a strategy for workforce development. And if there's no strategy, then we can't justify the funding. And if there's no funding, then we can't deploy peers into systems where they're desperately needed. So in the result, people are dying without peer support at the exact moment when it could save their lives, after an overdose, at an emergency department discharge, coming out of jail, exiting detox. It's a solvable problem, and we just need to name it, structure it, and fund it, because people already have this lived experience. So let's talk about DMC ODS. Almost no peers. So Drug Medi-Cal Organized Delivery System, DMC ODS. This is California's primarily publicly funded SUD treatment infrastructure. So according to DHCS, county monitoring reports from 2023, the average number of peers working with this is 0 to 63, with an average, of being 7. The median is 0. This means half of California's 58 counties have 0 certified peers in their substance use disorder treatment systems. So let's let that sink in. We have $4.5 billion opioid settlement. We have over 6,000 certified peers, and half of our counties have 0 peers in the SUD systems. Why? There's no structure, no specialization, and no clear pathway for counties to hire, train, and deploy peers supporting people who use substances. That's a gap. So in Riverside County, which is, I believe, the one out of all the 58 counties that has strong peer representation throughout their whole system. So they do have peers in the outpatient. I'm actually a recipient from an outpatient program where there was a peer embedded into that system. I'd like to say that helped me. It did not. I went externally to a peer-run organization and had a recovery coach support me. But they do have them in the treatment centers, they have them in the detoxes, and they have them in the outpatients. So peers are part of the system in Riverside County for Drug Medi-Cal ODS. So why don't the other counties follow? And instead of bringing it in-house, actually contract with peer-run organizations, and it'd be probably elevated if we had a specialization of peers to bring forth as a workforce and make this proposition. So SB 803 was built around mental health. Here's the reality. SB 803 and the 80-hour peer training were primarily designed for mental health recovery. That's where the majority of the curriculum focuses. That's where most of the examples, case studies, and competencies are drawn from. Now, I'm going to highlight that again. I've gone through several different trainings, and I have been in some where there is strong harm reduction being discussed, where there is a strong recovery groups that are being talked about. So it's not every training, it's not 100%. This is just as overarching as a whole. So I hope you guys can follow me with that. So California's peer movement has deep roots in mental health recovery and the consumer survivor movement. So it makes sense. But here's what's missing from the generalist curriculum when it comes to supporting people who use substances. There's overdose cycles and fentanyl realities. The curriculum doesn't address polysubstance use, fentanyl contamination, or rapid re-escalation of overdose risk. Harm reduction principles and safer use practices. There's minimal content on meeting people where they are, supporting safer use, or understanding harm reduction as a life-saving intervention. ED engagement strategies. Peers are being deployed in emergency departments with no training on how to engage someone who's just been revived from an overdose. And by that, I mean, we had the California Bridge program that funded a bunch of ERs, specifically with a SUNS navigator, a substance use navigator. When somebody would come in on an overdose, there would be somebody embedded there that would be able to support that person. And more often than not, that person had their experience in recovery. So they were there to support, but once that person exited the hospital, there wasn't any real follow-up other than their prescription to go get on their medication-assisted treatment, and that would be it. Now, what has been my understanding is, due to the way the money flows and the way that this can be funded, is through the hospital ER, there's a bundle now where it's community health workers that are part of the public health system to be able to be there to support that. And so that raises another question, is we have a lot of this other workforce that can or cannot be people with experience in recovery, not having, again, a specialization training of working with people in this capacity. So we always go on, we do no harm, right? So the ED engagement strategies, you know, the peers are being deployed in the EDs with no training on how to engage someone who's just been revived from an overdose. Trauma and survival mode, the training doesn't differentiate between trauma in mental health context and trauma in active substance use and survival context. Polysubstance realities, many people aren't using one substance. They're navigating fentanyl-laced stimulants, benzos, alcohol. The training doesn't prepare peers for that complexity. And then we have medication for addiction treatment and medication for opioid use disorder. Peers need to understand buprenorphine, methadone, naltrexone, what they are, how they work, how to support. And there's also something as the latest called contingency management for stimulant use disorder. So there's pilots going on, you know, people that are using methamphetamine. There's contingency management. There's another name for it, but the clinics call it that, of where somebody that is struggling with crystal meth addiction, that had no medical detox before, is they're trying to incentivize you to be sober or to not use methamphetamine. Right? So there's all of these things that are coming up that we need to be trained in order to work with people who use substances. So the generalist training, it's not enough. It can't prepare peers for the fentanyl and stimulant era realities of 2024 and beyond. We need the specialized training, and we need it. We need it now. All right, so there's peers that are being deployed into, as I said, emergency departments as part of post-overdose response teams, syringe service programs, street-based outreach teams, reentry programs for people leaving jail with substance use histories, mobile crisis units responding to 988 calls. I do want to highlight that there is an immense amount of people that are coming home from incarceration on medication, on MAT. And we're learning that there's a lot of people that actually were never opioid use disorders that are still being put on these medications. We're serving people that are trying to come off of this when they're coming home from incarceration. And so we need to have more education around this on working with people in this capacity. So we're doing this work without the specialized training in substance use support, harm reduction, overdose response, or the ethical complexities of the peer work with people who use substances. Now, it was also brought up to me when I asked this question about the specialization with this, and what was stated by the Department of Healthcare Services was that they were leaving it up to the organization that somebody went to go work for, right? And that organization, if they had some type of specialization or working with a certain population, that they would be the ones to then provide the training on how to work with people, which is okay, understandable, right? Not every organization is going to work the same. However, we have specializations to work with unhoused. We have specializations to work with people that have been incarcerated. We have specialization to work in crisis. So why not a specialization to work with people who use substances? So it's not their fault, you know, they're showing up with courage and lived experience, but we're setting them up to fail or worse, to burn out, to be re-traumatized, or to make mistakes that harm the people they're trying to serve. This harms peers and it harms the people we serve. So a PWS specialization protects both. It says, if you're going to do this work, here's the training, here's the supervision, and the ethical guidance you need to do it well and stay well. And I want to highlight a little story that was my particular lived experience when I first started the Happier Life Project. And as the founder, I was also doing direct service. I'm also part of a 12-step community, and I have a small community here. And I was supporting, there was a woman that was being supported by our organization. And she also had reached out to a 12-step line. And I would do that, you know, as my volunteer work, and I would take the calls. And what I did was I ended up picking up this woman at her home to take her to a meeting. And in the meeting, which was also my meeting, I shared about the experience that I was going through at that time. And that was that I had a significant other that I was living with, and he was still using. And I was in recovery, had started the Happier Life Project, but I was going through this challenging time of living with somebody who was still using substances and working through my own recovery myself. In doing that, this woman then, and I had to learn the hard way, reached out because she thought it was very inappropriate for me running an organization to be sharing in my own recovery space about living with somebody who used substances. And there was like a cross because she was being supported by a recovery coach within our organization, but I was doing my recovery work, which is the service work, to bring somebody to a meeting and to not understand that like maybe I don't need to share right now, and how those two things can cross from our own recovery journey, being somebody, you know, who's in recovery themselves, and then also doing this recovery work. So that's always something to, you know, to look at, you know, the ethical considerations, and just kind of taking care of ourselves in this work also. So let's see, next slide here. So I want to talk about BH Connect because this is a federal game changer. I got this wrong. Sorry, guys. So the federal guidance explicitly expects peers to be embedded into the SUD crisis pathways. So SAMHSA's best practice in peer support document published in 2023 names peer roles in the 988 call centers, mobile crisis teams responding to substance use crisis stabilization units, and post-overdose follow-up. So the federal expectation is clear. Peers should be a part of crisis response, especially for substance use. But California has not built the PWUS peer specialization to support this infrastructure. We're trying to build a house without the foundation. So BH Connect assumes we have a trained, credential PWS peer workforce. We don't, so let's build it. Here also, I'm going to speak to my experience. We work closely with our crisis response teams that are our UHS, which is the county, and we have a substance use counselor and we have a therapist. Those are the two that go out to the crisis calls. There is no peer embedded in that. And speaking to one of the counselors, he had shared that he was not sure how to utilize the peers, that he kept trying to have them come from the lens of the drug and alcohol counselor. Two very different roles. And this is one of the things when we don't have the specialization to understand, then you also have peers that don't really understand what they're supposed to or not be doing, or they just want to become counselors themselves. Not that there's anything wrong with that, but it leaves the peer role out of what it actually is, tried and true. So the BHIN 25010, the door is open, okay? State level. So January of 2025, DHCS issued the BHIN 25-010, and this is a formal policy directives to all counties. The notice stated peers are permitted across all SUD levels of care. So that includes residential treatment, intensive outpatient programs, withdrawal management, which is detox, recovery residences, medication for addiction treatment clinics, outpatient counseling systems. BHIN 2510 removes the ambiguity, right? So the state gave permission. Now we must build the structure. Counties need to know that if we hire a peer for our detox program, they're trained for that setting. Do they understand withdrawal? Do they understand the trauma, crisis de-escalation? Without the specialization, the answer is maybe. We don't know. There's no standard. Or, your organization should just train for that. PWUS specialization, the answer becomes yes, they're trained, certified, and ready to mobilize. BHSA, skip that, okay. So BHSA, the Behavioral Health Service Act, passed as Proposition 1, and it's a comprehensive overhaul of California's behavioral health system. And among its requirements, expand the SUD workforce to meet the growing demand, strengthen the crisis continuum to provide immediate accessible support. I'll highlight peer on respites, increase community-based services that meet people where they are, align mental health and substance use systems so they work together, not in silos. So every single one of these goals is advanced by a robust peer workforce that supports people who use substances. BHSA assumes that this workforce exists, but it does not. If BHSS requires the SUD workforce expansion, and California can't count, credential, or deploy specific peers with the certification of people who use substances, then we have a compliance issue. We have an opportunity here with BHSA implementing funding that could support the specialized training, peer hiring, and infrastructure development, but only if we build the specialization first. All right, so now we're going to talk about the opioid settlement, the $4.5 billion. This is the real money here. So California has received approximately $4.5 billion as part of the national opioid settlement with pharmaceutical companies and distributors, Johnson & Johnson, and the big three distributors and others. The money is being dispersed to the state and to the counties over 18 years. It's specifically designated for opioid abatement, programs and services that prevent overdose, support people who use opioids, and strengthen treatment systems. So here's the critical part. Peer support services are explicitly listed as allowable uses in the settlement agreement Schedule A and Schedule B, as well as Schedule F. So the allowable uses include peer recovery support services, post-overdose response teams, harm reduction programs, including syringe service and naloxone distribution, outreach and engagement, warm handoffs, and emergency departments. So counties could fund hundreds of peer jobs tomorrow for people who work with people who use substances. With the opioid settlement dollars, if they had a credentialed, specialized workforce to hire. So the money's there, the infrastructure is not. So this is why I'm calling the action to let's build it. So as a recovery community organization in Riverside County, I approached our board of supervisors to try to access this funds. And it's been since 2022, I've been trying to follow this funding because it specifically supports the type of peers that we bring into the Happier Life Project to support people in recovery, primarily from substance use disorder. Learned that in June of this year, the executive office, the board of supervisors, allocated every single dollar that was coming to this county. If it did not go to the cities, what came to the county, back to county behavioral health, every single dollar. So nothing went to the community-based organization. So now I'm going back and addressing this to see, like, are you going to be putting out a request for proposal for peers to serve in this capacity from the community? Because again, in Riverside, peers are within the same county system, right? So imagine that, right? You have money that pays for peers, but you also have a system that can bill for peers. And now, and that's what the county has. So not only did they take the opioid settlement, they're also the only ones billing for peer services. So that seems to be an issue, I would think, right? So again, the money's there, the infrastructure is not. So here again, the allowable opioid fund uses include peer. So let me get specific about what counties can fund with opioid settlement dollars, because this is where the opportunity lives. The counties can fund emergency department peers. Peers stationed in emergency departments to engage people after overdose, build rapport, and provide warm handoffs to treatment or harm reduction services. Now, I highlighted this earlier. We had the California Bridge Program, which was another funding stream that did that. Put what would be a peer, but they called them a SUNS, S-U-N-S, Substance Use Navigation System. Now, for those that no longer have the bridge programming funding, they've seen, okay, how do we keep this going? And they're embedding community health workers because it's funded through public health as a bundled rate in the ED. Well, not everybody has this, not every emergency room. So the opioid settlement funds could actually be something that is sought out for as a pilot to embed peers to be able to offer that support, even if it's not while they're in the hospital, as they're getting discharged, the warm handoff. But we need to have a specialization that highlights that there is this workforce that specializes in this specifically, okay? We also have detox peers, peers working in withdrawal management settings, supporting people through the difficult early stages of treatment. I myself have been into 3 non-medical detoxes. It literally was a home with people in recovery themselves that would come and give their time to support me while I was going through my detox stages that did not need a medical component in it, okay? There's also post-overdose peers. Peers who follow up after a non-fatal overdose, connecting people to resources, checking in, providing hope. And that's where our family peers can also come into that as well and help support the family after going through something traumatizing like that, like somebody overdosed. There's also housing navigation peers, right? BHSA, 30%, no additional funding, but it's moving into SUD and housing. Okay, well, guess what? Peers help people find and maintain housing, knowing that housing is one of the most protective factors in recovery. There's also harm reduction peers, peers embedded in syringe service programs, overdose prevention sites, and street-based outreach. Then we have our reentry peers, peers who support people leaving jail or prison with substance use histories, navigating the trenches reentry period. You know, when I'd come out of incarceration, you asked me if I had an issue with substances. Absolutely not. I just did 2 years. I didn't use it all the entire time. I did not have an issue. Yet 60 days later, I'd be back on a violation because I went to go pick up drugs, right? So just a little component there. Let's see. I think right now would be a good opportunity for me maybe to see if there's any questions that anybody has to place in the chat, or before I go on a little bit. Is that okay? Or if anybody wants to ask any questions or just kind of keep going.
Thank you, Carolina. There's been really great conversation following along with you. I don't see any recent questions in the chat, and I do not see anyone's hands raised, but they're really appreciating this conversation. And we're getting a comment. Thank you for this discussion. So needed.
Thank you. So I'll just keep on going. Thank you, everybody. Okay, so let me summarize where we are at, right? The missing infrastructure. So we have money. We have $4.5 billion in opioid settlement funds. We have policy. The BHIN 25-010, we have the BHSA, we have BH Connect, we have permission. State and federal guidance explicitly allows the peer roles. And we have the need. There were 6,473 overdose deaths. 114,000 were non-fatal overdoses. There's massive service gaps. What we don't have is a peer specialization for people who use substances. There's not a tracking system for the peers that are working with people who use substances. And there's not a workforce standard for people who use substances, peer roles. This is an infrastructure gap, and it's solvable. It's urgent, and it's within our power to solve. So the strategic logic, right? Gotta love logic. So piece 1, BHSA requires California to expand SUD workforce and strengthen crisis response. So one of the things also I want to highlight here is the Happier Life Project was awarded the BHCIP grant for the first peer-run respite in the Inland Empire. So the way the state even has the peer respite allocated or categorized, it's under mental health. However, being a recovery community organization, thank you, I see an opportunity to work with our people who use substances through that peer respite as well. I myself was somebody that struggled with a methamphetamine addiction. At the point that I got recovery, I reached out to some detoxes. I could not get in because it was a non-medical detox requirement. And this is about 4.5 years ago. And a peer respite would have served me well. I did not learn about them until after, but that is exactly the support that I could have had without wanting to go into an emergency room and designate myself 5150 just to get some quiet in my mind and some safety that I needed, because I knew that I wasn't in reality losing my mind, but I was because of the drugs that I was using. Peer respite would have been very helpful at that time. Okay. So anyhow, BH Connect and BHIN 25010 explicitly allow, and in some cases expect, the peers to be embedded in the SUD settings and the crisis pathways. So that's why I highlighted the peer respite. That is a crisis pathway that also supports people who use substances. So piece 3, the opioid settlement funds can pay for peer roles, including any pilot projects on ED peers, harm reduction peers, post-overdose peers. Piece 4 is the PWUS specialization is the missing infrastructure piece that makes all of this work. Without the specialization, counties don't know who to hire, peers don't know how to prepare, funding sits unused, and people continue to die without peer support. So with the specialization, counties have a clear credentialed workforce to hire. Peers get specialized training that protects them and the folks they serve, and opioid funds can be deployed strategically, and lives are saved. Okay. So we're not proposing to change the 17 competencies, right? So before we dive into the specialization and what it includes, I just want to emphasize that we're not changing the 17 core competencies. We're not altering the 80-hour foundational training. I know that there has been some conversations of maybe adding additional to that 80-hour and making that the main focus. So that, I mean, that could be something as opposed to its own specialization. You know, what we're proposing is adding a population-focused specialization, just like California does with justice involved, unhoused, crisis, family, caregivers. So it's not reinventing the wheel. It's actually following an established model. So the peers would still complete the 80-hour foundational training. And then those who want to specialize and work in supporting people who use substances would complete the additional 30 to 40 hours, focused specifically on that population. So the model works. It's already in use, and we're just expanding it to include the population that needs it the most. So the PWUS specialization is built around 9 core domains. So each domain represents a critical area of knowledge, skill, and ethical practice that peers need in order to effectively and safely support people who use substances. Now, I have followed the guise of every other specialized training that California has, because the more it looks like what they already have and what they have already approved, probably the simpler it is to actually get it addressed and accepted. So the domains are understanding substance use recovery. So that means the science, the brain, right? The lived experience and the multiple pathways. 2, engagement and motivational support, meeting people where they are, building trust. You know, the harm reduction. Number 3, safer use, harm reduction, right? Overdose prevention, consent-based care. 4, trauma-informed PWS care, understanding trauma in the context of survival and substance use. We also have the co-occurring disorder awareness, supporting people with both mental health and substance use needs. You know, we had somebody that worked with us. My mental health diagnosis exacerbated when I was on substances, okay? We had somebody that worked with us where it was opposite. They use substances because of their mental health condition. Very different, you know, in the way that the way that I received my support from a recovery coach / peer support, and the way that she received her support from a peer support specialist and her therapist, etc. Just want to highlight, you know, the differences. So boundaries and ethics in PWS settings. So navigating the dual relationships, managing triggers, protecting yourself and the people you serve. In the overdose and the crisis response, number 7, recognizing overdoses, administering naloxone, post-overdose engagement. In systems navigation for people who use substances, we have the DMC ODS, we have the medicated assisted treatment, we have medication for opioid use disorder, we've got housing, we've got benefits, we've got reentry, and then we have recovery and wellness planning. So supporting people in defining and pursuing their own recovery goals, right? So not the guise of, you know, abstinence is the only way. We're trying to get everybody off of substances. That's not the case, right? It's meeting people where they're at. So these domains, they match California's existing specialization structure, and they're designed to protect the peers and the people they serve. They're evidence informed and grounded in lived experience. So I want to go a little bit more into each one of them to give you a highlight. The foundations of substance use and recovery. So this domain covers the foundational knowledge peers need about substance use, addiction science, and recovery. So key topics in this is understanding that substance use often serves a purpose, managing pain, trauma, stress, or even being homeless, right? Also, stigma and shame, how stigma operates, how it harms, how peers can counter it. Return to use is part of recovery. Normalizing, supporting people through it without judgment. And then there's multiple pathways to wellness. Abstinence, medication-assisted treatment, harm reduction, they're all valid. And then there's the big one, which is recovery capital. Your internal and external resources that support your wellness. And there's actually an assessment tool that we use here at the Happier Life Project called the BARC-10, the Brief Assessment of Recovery Capital, or the ARC, Assessment of Recovery Capital. So also there's PWS-centered language, person first, non-judgmental language that affirms dignity, right? It's not the addict, it's not the, you know, the words that we know that can create harm. And why does it matter? So peers need to understand substance use beyond the disease model, beyond abstinence-only frameworks. They need to understand survival, adaptation, and the social determinants that shape substance use. So the grounds peers in compassionate, non-judgmental, evidence-informed understanding of substance use and recovery. And this comes from, so you know, the SAMHSA Tip 64, the recovery-oriented systems of care, the harm reduction coalition principles as well. So the module 2. On this one, we're talking about domain 2 is the way that I'm going to refer to it. Engagement and motivational support. So this one focuses on relational skills. Peers need to engage people who may be ambivalent, mistrustful, or not interested in traditional treatment, which is fine. Not everybody needs to go into traditional treatment. right? So the key topics here are meeting people where they are, the foundational principle of harm reduction, and the peer work. It's everything that we do, right? The motivational interviewing basics, open-ended questions, reflective listening, affirming strengths, the stages of change, understanding pre-contemplation, contemplation, preparation, action, maintenance, like where people are at in their stage of change when it comes to substance use and meeting them there. You're going to have a different approach. But if you don't know anything about the stages of change and you're using one way, and you could be really, really an amazing peer at your work and great at motivational interviewing, but you have to know where people are at in their stage of change to know how to meet them at that place. But you have to know what that is. Cultural humility, recognizing your own biases and honoring the person who you're serving in their cultural context. We also work with a lot of Indigenous communities, and the peer work looks very different. Peer support training that we have gone through in that, it's called Warrior Down. And it's primarily working with our men and women coming home from incarceration who have had a history of substance use, right? And that's different. That's not even anywhere in the California certification path or anything like that. But being able to learn about that and meeting the person where they're at and what their cultural contexts are and honoring that. So people who use substances have been often judged, coerced, or abandoned by systems. Trust is not automatic. It's built slowly through consistency, respect, and authentic connection. And peers are uniquely positioned to build this trust because of our shared lived experience, but they need the skills to do it effectively and ethically. Domain 3, harm reduction principles and practice. So this is one of the most critical and the most misunderstood domains. Harm reduction, and I'm going to also refer to it as risk mitigation due to political landscape, right? Fortunately, we're in California, harm reduction is embraced, but overall, at a national level, risk mitigation seems to be the term that is replacing harm reduction. Okay, so it's a set of principles and practices that are designed to reduce the negative consequences of substance use without requiring abstinence. So it isn't, hey, you need to quit, or hey, you can't show up to this group if you're still using. It's not any of that. It's reducing the negative consequences of their substance use without requiring it to be abstinence. So safer use education. How do you reduce overdose risk? How do you prevent infections? How do you use more safely? Also, never use alone. There's never use alone lines, right? There's start with the small amount, carry naloxone. Also, fentanyl and stimulant realities, understanding contamination, testing strips, changing your drug supply, safer supply concepts. What is it? Why does it matter? Where is it happening? And then also you have consent-based safety planning, working with people to identify their own risk reduction strategies. And then we have this, the syringe service program collaboration and how peers can support the SSP work. We're here with the Inland Empire Harm Reduction Coalition, and they're one of our syringe service programs that we're able to work with. So why does this matter? It's harm reduction, it saves lives, period. Not everyone is ready for abstinence, and not everybody wants abstinence. And people deserve to be kept alive and healthy regardless, of where they are in their stage of recovery. So peers need to understand what harm reduction is, not as a last resort, but as a compassionate, evidence-based, human rights-centered approach. And this is a citation from the Harm Reduction Coalition Principles, the CDC guidelines on syringe service programs, and harm reduction in the emergency room. Okay? We're going to go into domain 4, which is overdose touch points and system navigation. So most people who use substances have experienced significant trauma. This domain prepares peers to provide trauma-informed support in the specific context of substance use and survival. So the key topics here would include how trauma drives use and how use becomes a coping mechanism, right? So we have survival mode versus thriving mode. Understanding that many people are in survival mode, not in recovery mode. And then re-traumatization in systems, how healthcare, criminal justice, and social services can re-traumatize. And then supporting clients with complex trauma, PTSD, developmental trauma, ongoing trauma. And then also we have self-care for trauma-exposed peers, which is vicarious trauma, boundaries, sustainability. I'm sure we all have had some training in regards to that. And why does it matter, right? Trauma-informed care, it's not just a buzzword. It's about recognizing that trauma actually shapes your behavior, your relationships, and your trust. And it's all about creating safety, transparency, and choice in every interaction. And peers who have their own trauma histories are incredibly powerful in this work, and they're also vulnerable to being re-traumatized. So this domain protects both peers and the people that we are supporting. And this citation comes from SAMHSA's tip 57, which is TIC, trauma-informed care in SUD, peer-delivered trauma-informed care. So research shows that, let's see, did I miss one here? Like I'm missing a slide here. Let's see. Research shows that 50 to 70% of people with substance use disorders also have co-occurring mental health conditions, depression, anxiety, PTSD, bipolar disorder, maybe it's somebody struggling with schizophrenia. So this domain will prepare peers to support people navigating both. And this domain, I think I am missing something, is domain 5, which is co-occurring disorder awareness, right? So the key topics included in that is going to be the intersection of your mental health and the substance use and how they intersect, how they interact, and how they complicate each other. So I'll give you an example of my own journey. I had several diagnoses. I was put on some antipsychotics. I was very open with my psychiatrist about my substance use. And I would go through schizoaffective, right? I was schizoaffective. And so the medication that I was being given actually calmed that down, right? I didn't hear the voices. I didn't have those experiences that would come to me primarily when I was using substances. So in itself, the medication helped me keep using the substance because it took away the psychosis that I would go in from doing the methamphetamine. And I knew this and I wanted to stop, but I didn't know how. And so what I would do is I would stop taking my medication. I would stop taking my medication and I'd start losing it. And I was doing that purposely to try to push myself into getting help, to really like lose it in a way that like somebody's going to intervene, something's going to happen, or it's going to get so bad that I need to do something, you know, and there's nobody there walking me through this. Right. And so what help would that be? Having somebody, you know, who has had this experience, who understands who the primary diagnosis is not their mental health, it's their substance use. Right. And so I just wanted to highlight that because I see that, and I see that with other folks, you know, that we work with, that we support, you know, and vice versa, the other way around too, right? You get somebody that gets recovery from substance use and they're still experiencing or being somebody with schizophrenia, right? Like that is their reality and that is their normal. And to me, when I'm working with somebody in that way, yes, I can be there and yes, I can support them, but I remember this would be a trigger for me because the way that that person would share with me their experience, it took me back to my using experiences, and they're stone cold sober, right? And so it was very triggering, and I had to look at that for myself and get support myself in supporting somebody in that way. I'm not saying it can't be done, but just more education around it is helpful. So also the mental health, okay, so I already said that about the intersections, supporting the dual diagnosis. So understanding the unique challenges they face, you know, also crisis recognition and response, when to actually call for help and how to de-escalate, collaborating with mental health teams, how peers fit into integrated care, and then also the DMC, ODS, specialty mental health, the CalAIM, and the ECM. So navigating these integrated care systems that can be very complex. So why does this matter? The co-occurring disorders are the norm, not the exception. So peers need to understand how mental health and substance use interact and how to support people holistically without overstepping their role. So this domain also prepares people to work collaboratively with the clinical teams and knowing when to refer and when to support directly. And that's a citation from SAMHSA Tip 42, substance use treatment for persons with co-occurring disorders. Okay. And then domain 6, we have boundaries and ethics with people who use substances in those settings. So in that, domain 6 is boundaries and ethics. I just said that. With people who use substances settings. So the domain addresses one of the most complex part of this peer work, boundaries. We often have dual relationships. We may know our folks from the community, from treatment, from the streets. They may be in their own recovery while supporting others, which has always been my experience. We may be triggered by people we're serving, by their stories, by their behaviors. And this domain gives peers the tools to navigate this ethically and safely. And the key topics in that include navigating dual relationships. When is it okay? When is it not? Managing triggers and personal boundaries, recognizing your own limits. Confidentiality and harm reduction settings, right? Balancing trust and safety. Ethical dilemmas unique to this work of supporting people who use substances. What do you do if a person you're supporting is using during your session, right? They're not in an abstinence thing. What do you do? What if they're in danger? What if they disclose illegal activity, right? When to refer versus when to support, knowing the scope of your role. And why this matters is within clear ethical guidance, peers can burn out. Without clear ethical guidance, peers can burn out, return to use, or harm clients unintentionally. And this domain provides the ethical scaffolding that keeps everyone safe. And I will highlight this, as being an organization that hires people in their own recovery journey from substance use. How do you supervise and how do you work with somebody that returns to use? You know, that decides that their abstinence model is no longer the way they want to go, they're going to practice harm reduction. Right? In your organization, or, you know, there's somebody that says they're abstinent, right? Because they disclose, and you're going to your own recovery meeting and they raise their hand up as a newcomer, right? How do you navigate these things? That's a whole nother thing under supervision, right? So then there's domain 7, which is the overdose and crisis response. And that's peers working with peers who use substances that are often first responders to overdose. And this is different in all the counties throughout California. In some places they do, in some places they don't. But this domain prepares them for that reality. So respiratory depression, the blue lips, the unresponsiveness, right? Recognizing the overdose signs. It's like we have to know this. You know, we're educating people on naloxone, on how to recognize an overdose, how to administrate it, how to use it. Injectable naloxone, nasal spray. Also, how to connect with someone after they've been revived. Processing the experience, reducing stigma, connecting them to resources. So supporting the peer after non-fatal overdose. Crisis de-escalation techniques, how to calm someone in acute distress, and when to call, what to expect. Like we've had in our center people who need their next fix or to do some more drugs, and they are escalating. You know, they're in that they just need to get high, right? And it's not this mental health crisis that is looked at in this different way. It's like understanding and knowing like these different situations that do come up and being equipped as a peer on how do you support, when do you call, when do you connect to 988, when do you call the mobile crisis? Does your area that you live in actually have a supportive, mobile crisis? Is it another community-based organization? Is it the county? Different things like that, when to call, what to expect. So overdose is a daily reality for many people who use substances. Fentanyl isn't everything, right? So peers need to be prepared, not just with naloxone, but with the emotional and relational skills to support someone through a life-threatening crisis. And this domain, that I just went over, the overdose and crisis response, can literally save lives. And the citation for this domain is under CDC naloxone training guidelines and SAMHSA's overdose prevention toolkit. And I'm sorry, but I don't know why my slides just stopped. But domain and system navigation for people who use substances. And so the California systems, they're fragmented, they're bureaucratic and hard to navigate, especially for people who use substances and are often dealing with being unhoused, having criminal legal involvement, or even lack of documentation, right? So this domain teaches peers how to navigate these systems on behalf of the folks they're supporting. So the key topics on this is the DMC ODS levels of care, right? What is that? That wasn't something that was that has gone over in any of the trainings, right? But this is the population that we're working with. How do you know how you can support them if you don't know the levels of care that are actually there? Outpatient, IOP, residential, withdrawal management, recovery residence, recovery support services. There's also the MAT, access and navigation. How do you get norepinephrine? How do you get methadone? How do you get naltrexone? You got a pregnant woman that's using that needs support. Do you connect them, or do you have your own judgment because they're pregnant and they're using, right? So these things of being able to understand what that actually means and be able to go through this and understand how to help somebody. How to enroll them in benefits, general assistance, CalFresh, Medi-Cal. We do that with we have folks that are dually certified as CHWs, as well as recovery coaches, as well as California certified peer support specialists. And then also as credible messengers, right? Working with our reentry population. So navigating probation, parole, record clearance, reentry services, warm handoffs from the ED, detox, jail, shelter to ongoing support. And why does all of this matter? The systems aren't designed to be accessible. They're designed to gatekeep. So peers break down those gates. They walk alongside our folks through every bureaucratic hurdle. And this domain equips peers to be expert navigators because it is a complex system. And this citation is from DHCS DMC ODS, the provider manual, and CalAIM Enhanced Care Management Guidelines. So domain 9 is recovery and wellness planning. And this is the final domain that focuses on supporting clients in defining and pursuing their own recovery and wellness goals. And what this includes is recovery action plans, right? It's a peer-led tool for wellness planning. I have one myself, and I actually recommend peer-run organizations when you're bringing people on to have that like as an exercise for anybody that's working with you, especially if there are people in recovery from substance use. I mean, in recovery from anything, actually, is have your wellness plan as the people that are working within your organization, as well as the people that we're supporting, right? So also goal setting with our folks that are using substances or have used substances, how to set achievable self-driven goals, right? Building recovery capital. Again, like what is recovery capital? Your social, physical, human, and community capital. How do you build those internal and external resources? And then normalizing return to use, actually having a plan for it and responding without judgment. That's the relapse prevention and response. And then celebrating progress and milestones, affirming growth, no matter how small. We love a reason to celebrate, how much time we're doing, X, Y, and Z, how much time we have in recovery, or how much time it's been since, we've had this behavior or used this substance. This substances, it's celebrating the progress and the milestones. And that matters because recovery is not linear. It's not one size fits all, and peers help our folks define what recovery means for them and build a path that actually fits their lives. So this domain honors autonomy, it celebrates progress, and it keeps hope alive. Hope alive. All right. So what does this look like in practice? The PWUS Specialization would be an additional 30 to 40 hours of training structured around the 9 domains that we just reviewed. So it would include lectures, videos, reading on each domain, didactic content, real world scenarios peers will encounter. So some case studies, some role plays. I shared some of my personal experiences. It will include guest speakers with lived experience, people in recovery, people currently using, family members, skills practice, naloxone administration, motivational interviewing, crisis de-escalation, and also supervision and mentorship, ongoing support from experienced peer supervisors that have worked with people who use substances. Another thing that we do at the Happier Life Project, and it's open to anybody that works here, is to have your own recovery coach. People may have their sponsors, they may have a therapist, they may have a faith-based pathway, but we offer a recovery coach who's also a certified life coach to everybody that works here if they so choose to help them. So it's not just a checkbox, right? There's a comprehensive, rigorous, practice-based training that prepares peers for the actual work they will be doing. And critically, it's standardized statewide training. So every PWS peer in California would receive the same high quality preparation no matter where they live or which agency hires them. And this is what I feel California has been missing, and this is what we can build. So what we can build. Let me paint the picture of what changes with the PWS specialization. So the current reality, right, is a county wants to deploy peers in different ways for post-overdose response, or not actually have peers, but have other folks that may not be trained in this way, right? So they hire a generalist who completed that completed the 80-hour training. That peer shows up full of heart and lived experience, but they were never trained in overdose engagement, harm reduction, or even the workflow of the emergency room. And they're burnt out in 3 months, right? Because what they know is their own recovery journey of the way that we do, the way that we support people in the rooms, whether in 12-step community in whatever way, shape, or form that is. We just haven't learned it in a different way, right? So we burn out. With the PWS specialization, the same county will hire a peer who's completed the 80-hour foundational plus the 30 to 40-hour specialization. And this peer shows up with training in overdose response, harm reduction, trauma-informed care, and the ED engagement. And they're supported by supervision, so they thrive, they save lives, and they stay in the role. That's the difference, right? Peers deserve preparation. Are the people we support, not clients, deserve competent support. California deserves a peer workforce that actually works with the specialization with people who use substances. So the data problem. So the data problem I named earlier, right? So right now with what I searched with Cal Mesa, since they're the trainers of the peer support certification, I could not find any way or place that they counted the peers who supported people who use substance. So didn't know who they are, where they work, or what impact they're having. Now I'm going to go again on this side. On the billing side, I'm almost 100% certain that every county does have those numbers, because if they're billing and getting reimbursed for it, there has to be a track somewhere of where this is coming from. It's just not something that was provided under the meetings with Cal Mesa, where they go over how many peers have we certified, anybody has specialization, things like that. So just want to give that disclaimer, okay? So once the specialization exists, peers can be certified in it. Just like that, they can be certified in the other specializations. So this is what the specialization of working with people who use substances would solve. We would be able to be counted and know what impact we're having and where we actually are. And so what that means is DHCS can now track how many certified peers for people with specialization on people who use substances, and the counties can report the peer deployment in their annual plans, right? We can now say that with what the BHSA is required, SUD workforce expansion. You can't really highlight us specifically, like if there's a specialization, you actually can. And then funders can justify the investment based on the workforce capacity. So when we can track it, we can fund it. When we fund it, we can scale it. And when we can scale it, we can save lives. So visibility is the first step. And this specialization creates that visibility. How do we get the funding, right? Unlocking the county funding. So here's how the PWS specialization can unlock funding at the county level. Again, these are all my thoughts on slides aside from the stuff that I'm sharing has citations. And counties are different, right? Riverside County is very different than LA and San Diego. But the one thing that is the same is the counties are sitting on opioid settlement dollars. Okay, they want to use them effectively, but they're risk averse. They need to justify every expense to the county board and to the state and to the public. So I was advised by 2 of our county supervisors that no other community-based organization had approached them about these opioid settlement dollars. Not one. Okay, Inland Empire, Riverside County is huge. The Happier Life Project was the only one. That's a problem. That's an issue. And so what they did was they gave it back to county behavioral, or they gave it to the county because they said they needed it, right? And so they gave it to them, every single dollar. So for the year. Okay? So right now, if the county wants to hire peers for overdose response, they face questions like, are these peers trained for this work? What's the scope of their role? How do we supervise them? And how do we measure their impact? Okay, so without a specialization, the answer is unclear. So the funding will sit unused or used in other spaces and places. With a specialization for people who use substances, the answer becomes clear. Yes, these peers are specially trained in overdose response, harm reduction, and engagement with people who use substances. The scope is defined by the 9 domains and the supervision is part of the training and the structure. And then impact can be measured because we're tracking a defined workforce. So suddenly counties have justification for opioid settlement fund expenditures. They have proof of BHSA compliance, which says expand the SUD workforce, right? They have alignment with Drug Medi-Cal ODS requirements, which says peer support across all levels of care. Then the PWS specialization is the key that unlocks millions of dollars of funding that already exists.
Carolina,
Yes.
can I just let you know we have one person who has their hand up, and they may have a question to some of the slides that you just went over.
Absolutely. Please.
Stuart, are you there?
Yes, can you hear me?
Yes.
What about RAP? And it's not recovery action plan, it's wellness recovery action plan. That was first taught by Mary Ellen Copeland.
Yes.
And it consists of your daily maintenance plan, trigger identification, early warning signs, crisis plan, as in advanced directive, and a post-crisis plan. And personally, the post-crisis plan to me is the most important part, because if you end up in say a hospital, the advanced directive will take care of you, in that you have in writing, when you were mentally stable, where you would like to be sent and where you won't like to be sent, who to oversee and who not to oversee what happens to you, and so on and so forth. And the post-crisis plan is you go back and you identify why you broke down. So I'm surprised that rap isn't mentioned at all in here.
May I? Yes. Thank you for your comment and highlighting that. And it is actually I said recovery action plan. It is RAP, Wellness Recovery Action Plan. What I was just very careful to do was I understood there was some evidence-based issues around who actually now is allowed to do RAP, et cetera. I know it comes from Copeland. It is a wonderful, wonderful implementation that I think everybody should have. I have my own RAP plan myself around my substance use because specifically when I am in recovery, I know what it is that I want if I would return to use. Without it, when I'm in my addiction, you are not going to get the same story from me that you would have gotten from me when I was in recovery. But if you're allowing me, right, in the way that it's said and in our peer work and in our peer roles of meeting somebody where they're at, of being able to respect what it is that they want, I'm here to tell you, I'm going to give you a different answer when I'm using than when I'm not using. And so I needed that highlighted for myself, and I encourage that for people, both in mental health and substance use. So thank
May
you for
I add
bringing
one
that
other
up.
thing?
Absolutely.
One other thing I found extremely powerful, and now Oxnard Behavioral Health that I volunteer at is starting to teach is cognitive behavioral therapy, CBT.
Mm-hmm.
On my father's deathbed back in '89, he was reading a book, Feeling Good by Dr. Burns, William Burns, I think, on cognitive CBT. And it's basically don't take it personally. If someone's opinion contradicts yours, hey, it's their opinion, right or wrong. Who cares? Take it under advisement.
Absolutely. Thank you for highlighting that as well, right? And so,
And for
even
that
though,
matter, what about Jungian psychology? Uh, that that problem, if you think of your situation as an onion, uh, and whatever's bothering you is the outer layer of that onion. And if you think about it a little bit, that outer layer disappears once you become aware of what the root cause was. And the neat thing is, okay, now that outer layer is not a problem, but what's the next part of the problem? And as you keep working on this, the onion keeps getting smaller and smaller and smaller until eventually, hopefully, you realize what the root cause of it was in the first place. And then all of a sudden, it's not a problem anymore.
right. And thank you so much for providing those contexts on that. And what a wonderful thing, right? Even though peers cannot clinically provide cognitive behavioral therapy, they do use and can use cognitive behavioral therapy informed tools, right? So thought awareness, reframing, coping strategies, behavioral support skills. That's all part of our lived experience, having gone through the recovery process ourselves. And these are tools that empower people to choose new responses, right? And so that's what this is all about. And thank you so much for sharing that, and that you have found that useful, and for highlighting that for us here today. Is there any other questions?
No, that was it. Thank you so much, Carolina.
Absolutely. And I
I'm
know that
sorry.
yes.
I'm sorry. I just had a quick question. I like the way you phrased that. You said that although we can't practice cognitive behavioral therapy, we can apply learned, or how did?
Yes. So we're not like as peers, right? We don't provide clinical cognitive behavioral therapy, but we do use cognitive behavioral therapy informed tools. You know, and those are like they're natural in the lived experience, right? So I want to highlight that, right? The thought reframing, the awareness of like, why do I think that? Like, let me challenge that. Like that, I don't need to be a therapist to do that with myself or to offer that for anybody else. So I just want to share that and highlight us and the work that we do. It's CBT informed tools that we get to use. Does that answer your question? Or
Love that. Thank you. Yes, I like the way you phrased that.
thank you. Thank you so much. Anybody else want to comment or ask any questions? Okay. All right. Yeah, let's see. So how much time do we have?
We have about 20 more minutes left, depending on how many slides and time for
Okay.
questions.
Okay, if anybody has any questions as we're going through this, please, by all means, just raise your hand or put it in the comment or in the chat, and it will be addressed as we're going, and I'll stop at any point, okay? All right, so let's continue here. So the economic impact I want to talk about, and the jobs and the investment. So the economic and workforce impact of creating the specialization. So imagine that each of California's 58 counties, and I know all of them did not opt in, because I know San Bernardino right next to us did not opt in. Say they hire just 5 specialized peers with the new certification, right? That's not a huge lift. That's 5 peers per county. Say all 58 counties were opted in. I don't know how many we have opted in, but that's already 290 new peer jobs statewide. So at an average salary, which I think is super modest, which is $65,000 per year, or anywhere from $50,000 to $65,000 per year. Modest but realistic for entry-level peer roles. That's an annual investment of $14.5 million. So now, where does that money come from? Opioid settlement funds. It's already there. It's already allocated for exactly this kind of work. And so here's the beautiful part. It's sustainable. It's long-term workforce investment. These aren't one-time grants. The opioid settlement funds are distributed over 18 years. So counties can build a stable, professional peer workforce specializing to work with people who use substances and sustain it. Okay. So the kicker right here, okay, so look at this. Peer support isn't just compassionate, it's cost effective, right? And so there's fewer crisis interventions, fewer costly hospitalizations. Peer support reduces emergency department visits by 30 to 40%. Peer support increases treatment retention by 25%. And people stay in treatment longer when they have peer support, which means better outcomes and lower return to use rates. And this is all documented. So peer support is one of the highest return on investment interventions in behavioral health. I'm going to give an example of the difference in counties. So in LA, to have a peer do service under substance use, it pays very, very little, okay? So most treatment centers aren't going to employ peer support specialists because they have people like techs, the BHTs or the RADT, that they get a return which is a lot higher than hiring a peer and billing for their services. However, in Riverside, if you look at the billing codes out here, it is really high in substance use. And lo and behold, in Riverside, we have tons of peers in substance use through the county system, not through recovery community organizations or not through peer-run organizations, but through the county itself. So I find that interesting. It's an interesting fact. So I invite you to look to see what the reimbursement rate is in your county for peer services in SUD, so DMC ODS. So when we invest 14.5 million in peer salaries for people supporting our peers with the specialization of people who use substances, we're not creating jobs. We're saving 40 to 100 million in avoided crisis costs, ED visits, hospitalizations, and incarceration. So it's really smart policy, and it's a smart investment, and it's really just the right thing to do. So before we move into action step, I want to ground us in evidence because it's not experimental. It's not experimental. Peer support for people who use substances is evidence-based. And here's what the research shows. People who work with peers are more likely to enter treatment and stay engaged. Peer support reduces psychiatric and medical hospitalization, including overdose-related ED visits. People report better overall quality of life, more hope, and stronger social connections when they receive peer support. Peers uniquely provide hope because they embody the possibility of recovery. And as I mentioned, every dollar spent on peer support saves 3 to 7 in crisis cost. So the evidence is clear. We know that peer support works, and people who use substances, peer support works. We just need to put out the framework on how this needs to go. For the counties to understand and for us to have a specialization in order for them to utilize peer-run organizations and peer support, not a specialization. And so California is not the first state. Other states have already created a peer certification specialization under SUD. And so that's where I draw to let's learn from that. So New York has certified peer recovery advocate credential, which has a specialized training for SUD settings. Vermont has peer recovery specialist certification that's integrated into their hub and spoke model for opioid use disorder recovery. Connecticut has recovery support specialist certification with a strong focus on substance use and harm reduction. Pennsylvania has certified recovery specialist credential, and they're working in addiction recovery, and it's widely recognized and it's billable under Medicaid. So we are not the first state. People are already doing this. California is actually behind on this, and we're the largest state in the nation, and we have the most robust Medi-Cal system. We have 4.5 billion in opioid settlement funds, but we do not have a peer certification to work with people who use substances. So we have the opportunity to actually build a model, one that's equity centered, harm reduction affirming, and grounded in lived experience, especially when we have a landscape nationally that is shutting down things like harm reduction. We are a state that embraces risk mitigation. We have to set a way to be able to support this workforce to be able to move forward. So there has been some concerns that I've heard, when developing the proposal is, will the specialization create barriers to becoming a peer? And it's no, because it's not mandatory, it's optional, right? So you still do your 80 hours, it's an optional thing, and employers can look at that. If it's something that they would like or require or pay for you to do it, that can be something. Does it expand billing opportunities? So specialized peers can bill at higher rates depending on the county or access funding streams that perhaps a person that does not have this specialization can access. And it creates a career ladder. So peers can start with a foundational 80 hours and gain experience and pursue a specialization as they grow in the field. And more training equals more opportunities, not fewer. Okay. The other concern that was brought up is we already have peer training. Why do we need another one? And as went through this whole presentation, that training is not enough to work with people who use substances, right? The foundational training is excellent for what it covers, but it's primarily mental health focused, and it doesn't adequately prepare peers for fentanyl saturated drug supply, overdose response, naloxone administration, multiple pathways, harm reduction, safer use support, navigating the MAT, the MOUD, and supporting people in active use. So if the BHSA requires SUD workforce expansion and BH Connect mandates peer integration, and California cannot count or track peers, or they're not, or Cal Mesa isn't, rephrase that, peers who use substances, then it looks like we have a compliance issue here. Do we have any questions at this point?
Let's see. The last question I see is, are we allowed to take those out of state courses and be usable here in California? And there was another question. Can you please share the CPT informed tools, resources, and books you recommend?
So I will answer the first question. So what we did at the Happier Life Project when I first started this is a recovery community organization, which is actually nationally recognized. There's recovery community organizations all across the United States. There's about 6 of us here in California. California does not recognize us, right, as anything, nor are we funded through any specific stream as we are through many other states. So what I did is I brought some of those trainings from other states and certifications to our employees that we had here, because that's the work that we're doing. The reason that I then had people get trained as certified peer support specialists was only as a workforce issue and not doing a disservice to anybody that came to be employed with us. Because if they decided to leave and they're doing this work but don't have this certification, they may not be hired anywhere else, and they just did all this time here with us and learning and experience and training, but didn't go do the certified peer support specialist training in order to go work somewhere where they might be able to bill. So yes, you can absolutely bring that to your organization. You can take the trainings yourself just to equip yourself in that. It is just not something that is recognized in California, and that is what we are advocating for, that it is actually something that is recognized. Other states have the certification. It is billable. It is part of all of this new transformation that is going on, and it is a way for us as peers, who a lot of us feel or fear that BHSA is pushing peer-run organizations out, when in reality, there is actually a whole aspect of the peer work that is not being utilized in the way, because there's nothing to highlight it or specify that we're here in this way and we're trained especially to do this work that the governor is requiring that all counties do, and that's expand the SUD workforce, and peers do that all day long already. So I hope that answers your question. So yes. What did I do here? Any other questions? And then I think I got the question of the tools, right?
We have Jared. Go ahead.
Hi, Carolina. I really enjoyed the presentation. There was a lot of stuff there, but you did a great job presenting it. And I work for an RCO in the Bay Area, and we're one of the only ones out here, or possibly the only one. And we are not able to bill Medi-Cal as of now because we don't have any clinicians. We're just all peers. About half of us are peer support specialists and recovery coaches. The other half are recovery coaches. But as of right now, we haven't been able to bill Medi-Cal. Do you think with this new specialization that could help us to be able to bill Medi-Cal without a clinician, or do you think that's possible?
So you must be with Voices San Mateo, right?
Yep.
Yeah.
Voices
Okay.
of Recovery, San
All right.
Mateo County.
Yes, so we're also part of Faces and Voices of Recovery nationally. So it's good to have you here, Jared. Thank you so much. So that's a twofold question. Will this specialization allow us to bill? So that is now like more policy, right? That's the 1115 waiver, which other states have actually done this, where RCOs like ourselves are able to bill Medi-Cal because we're included. We're not just, so it's not just like harm reduction, treatment. It's actually RCOs are written into the verbiage to be able to bill directly, because as we know, peer support is a standalone service. And so again, that's more policy legislation. However, another workaround that I've been working on, and I think that more of us need to come together around this, is if you have all this space that SUD workforce needs to open up into, right? And currently the landscape is it's just treatment, right? That's being funded. Is how do we position ourselves as peer-run orgs to elevate, be excellent in the service delivery, and help create a subcontracting process with those that are already working with the county for those codes that they could build but they do not use. Who would use them? We would use them. And so we would need to then come together saying, hey, we're all specialized training in this, and this is what the training looks like, and we're equipped to do this, and we're training everybody, and we're doing this, and we're doing that. Now let's come together, and what does the subcontracting process look like to the people that already have the access? Because the counties will let them use those billing codes, but use it from the peer-run organizations that are tried and true and trained. But right now, when we're not, we can't elevate that and use that and bring that to the table. Does that make sense?
Yeah, it makes sense.
And it keeps us, it keeps the peer, right? And it keeps us doing this work. And I think that that's something that we can absolutely do.
Awesome. Thank you. I look forward to taking the specialization.
Yeah, it's not, I'm still fighting for this, so.
Yeah, when it comes out, that's what I'm saying, in the future.
Thank you.
Thank you.
Yeah, absolutely. Anybody else have any questions? All right, I think we're almost out of time, and I don't know.
I have a question real quick, Caroline. Can you hear me?
Sure. Yes. Hi, Misty.
How close are you into, how far along are you in the process of having this completed? Like, have you taken it, to the Capitol? Like, how far are you in, accomplishing this task?
So I've met with both. I've met with the people from DHCS, even though Cal Mesa is the one that does the certification. I met with the DHCS folks that needed the convincing that can direct Cal Mesa to create the specialization. And so I'm stating my case with this. And now with more of the BHSA, like they're waiting for my proposal, right? What do you got, Carolina? They're like, what are you proposing, right? And how would this look? And so this has been actually a beautiful segue for me because I was already doing this work, and that's why I wanted to do this presentation, because we're going to need to rally the troops, right? We're going to need to rally the troops because on the other hand of mental health, we also have, even though we're saying integrated, right? We have a very direct line out of treatment and services that are provided under certification under our certifying bodies by the state. Right? So that's our CCAP, our cadets, that's all these people that certify drug and alcohol counselors, right? They also have some certifications for peer support specialists, but those don't bill Medi-Cal. So there's still this very big separation that I really feel that that's why the state kind of eased off of having so much in specialization for SUD, because there's these other entities that call themselves covering treatment in SUD. But there's the whole recovery support services that peers that are currently here now can absolutely take. So probably within the next week and a half, I will do my presentation with those folks from Department of Healthcare Services and go from there. They've already opened that door for me to offer up what we were proposing, and it's only taken 3 years to actually hear me.
Yeah, only 3 years, huh?
Right, because I said this at the very beginning. I was like, ooh, this doesn't actually cover, and I know this because I'm doing the work as an RCO, but I've had to implement myself as just a peer-run organization with like, okay, I'm just here on both, behavioral health, but really it's the same, but it's not the same. Right, as we all know, and Voices of San Mateo, Voices of Recovery San Mateo is going to understand that as well. We do actually support, co-occurring, there's some level of mental health as well, but primarily it's recovery, the recovery support from substance use. So there's decision makers who have the power to make the specialization a reality. You know, we have DHCS, we have CalMesa, I'm in conversations with the California Behavioral Health Directors Association. You know, we have SAMHSA to pull off of because they can support California in building this infrastructure, and then the legislature, right? And especially right now with the BHSA and what is being required of the counties to do, and they're not maximizing it because they don't even know we exist. Peers are like this thing that's like not, I don't know, not something that's being recognized and needs to and can actually be part of bringing funding to the county table, which is when they'll listen.
Now, speaking of funding, Caroline, I know that the peer support specialist that you were just talking about is a billable service through Medi-Cal right now. What
Yes.
is the differentiation between the peer support specialist and the CHW as far as the billable services? Are they being pulled from the same financial spot?
No. Peer support specialist is county behavioral health carve out, the, I don't know, H00038. Community health work is through the managed care plans. It's public health. So it's in a different lane. You know, and community health work is the latest that I knew is billable at 30-minute increments. And it's like somewhere in our county at like $27 for 30 minutes. And it comes from the managed care plan, and it's different. Yes, a community health worker can provide individual support as part of their domains, but it's different than the peer support specialist. And the billing rates in our county for peer support specialists, you're way over $150 as compared to like, I don't know, 54 for a community health worker for an hour.
Okay, thank you.
Very
Thank
different.
you. Very knowledgeable. Thank you.
You're welcome. Anybody else? Okay. So I just want to say before we're done here, 3 minutes, right? Action. You will, hopefully with your permission, right, as I get ready to get this out, and if I need, you know, some support, some organizations or other people that can highlight and stand behind this, you know, I'll work hopefully with Cal Voices on this to share information and see if people can be a part of this, because you know, if you hold institutional power, you know, use it to open the doors, not close it, redistribute decision-making to people with lived experience, fund the peer leadership, not just peer labor, and step back when your voice centers you instead of community. And it's a movement, not a program, right? Let's build something different, you guys. And we have to come together and organize. I highlighted very much so how there is this opioid settlement funds in the entire state of California. How do we utilize them to support the peer workforce? In order to do that, we have to have a specialization to show that this workforce is acutely trained, is very much in there to go to support everything around the opioid remediation. So thank you so much.
Caroline, this brother Suja, I got
Hey,
a question.
Suja. What's
How
up?
we doing?
Good.
With this current environment, vibe in California now with Proposition 1, the modification of the Mental Health Service Act, and the cutting of PEI providers, specifically here in Alameda County, but throughout California, and the new language for now, early prevention, because we all do this work, but you know, peers are one thing when you work for one thing, but when this is a movement. And how do we keep our brother and sister organizations who don't have the bandwidth to 2 years, 3 years to get psych certification, Medi-Cal billing in that capacity, and cash flow to do all those things, to keep people jobs? Because you mentioned it over and over. This is workforce development and job security for our communities. But with the splintering of the peer movement, with certification, those are worth money who can bill for Medicaid and Medi-Cal. But as an individual and getting that contract, that's too far. How do we, in making this movement, thank you, I will be calling you. I think I just sent you that message. But how do we come back and remove this anxiety from the orgs who hire the peers and change this language in a timely fashion. When these cuts come out this year for 2000, we don't have 2 years and 3 years to shore up to be able to do that. And the fast track it, you know what we've been doing. And how do we work? Because everybody busy, but to keep these CBOs in to get these contracts and that funding, and the staff to do all these things. I've been watching. It's really been 6 years you've been working on this.
No, 4.5.
So when we talk to our peers, because we don't share that part being an employer with employees, but we're talking about employees and employers here, and how could we shore this up and continue to make this movement grow would be my thing. Because some of these things, when you just look at what you got to do, and you're already stretched out, what could be some wellness tools and some support. If I would ask for anybody, for us, we need some people to come in some kind of way and build this infrastructure in these smaller orgs who have to bear this burden with this, the annihilation of the Mental Health Service Act. So how do we build up when you ain't been building up, and now all this new language and all that, you're a fast actor, but that's not the norms in here, especially if you have under $1 million.
Right. And I think that that's a loaded question and could very much create so much dialogue, that I invite you to connect with me separately, Suja. But I will say this, being an organization that in the last 4 years has not received $1 out of the MHSA, and being peer-led, peer-ran. I've never gotten $1 out of anything that MHSA had. I didn't even know, in all honesty. I went for state funds and was doing it all sorts of different ways. I have a different experience, and different counties are different, right? So you're in a county that I thought was so beautiful that they funded so much peer-run organizations. My county in Riverside, none of us. There's not one that they fund. So I was like, oh my gosh, I need to be in Alameda County. However, yet now look, the stark difference is like, oh, now they're going to pull it out of there because they were giving those funds, and now you guys have nothing. However, I invite you to position, and this is what I'm looking at, because the BHSA is moving the 30% over to housing and SUD. There it is. Okay, housing and SUD. Okay, it's not mental health peers against SUD peers. It's let's get a specialization for SUD. So we are those peers in this funding that's coming over here to encompass SUD also, as well as in housing, peer supports. So I've always been the HUD. Okay, so I was looking at the HUD grants, and HUD was federal grants, makes requirements. If you're going to house somebody, you have to have supportive services with it. Well, who provides the supportive services? A peer. A peer can provide the supportive services. So we come as together in it and learn how to insert ourselves in that way. I mean, again, it's very much derived on what county you're in, how they're navigating, how they're doing it. So for me to give a blanket answer to that, I cannot. However, one big blanket answer that I will give, and I've done this under the SUD and tried forming this, is if we had one agency that was peer-led, peer-ran, that had the SUD folks that had already county contracts to bill for these services, could then be a hub for us smaller peer-run organizations to subcontract for the peer work, then we wouldn't have to change who we are or the structure of it. There's already somebody that's gone through the whole certification, licensing, all the stuff that DHCS requires. It's too much for us, and we just subcontract under them and figure out how that works individually. But that, again, has to be done county by county. So, yeah, thanks. Anybody else? So we have the law, we have the money, we have the people. Now we need the will, and we need to organize. We need to organize. So this is our moment. These CPP planning processes are going. We must be embedded in there, but we have to show, right, like what our value is. And again, it's individually county by county, that I can't speak to every county. And with that, I'm complete. Hello?
Thank you so much.
Hi.
Sorry, go ahead. I think somebody has a question.
I just had a quick question. When I
Yes.
was logging on, I think you were you filling, or is the group filling something out that I may have missed? And was this, do we get a certificate or some kind of acknowledgement for being in this webinar? Or I'm not sure if somebody asked that.
I think what you may have been filling out was just our demographic poll. And we just try to capture the majority of participants. So if you didn't get a chance to finish it, that's okay. And unfortunately, we're not able to offer certificates for our virtual webinars.
No problem. Thank you. It was great information.
Yeah, Anna.
Thank you.
Jared, I think we need to connect. Or actually need to connect with your AD too.
Yeah, that'd be great. I actually sent you my email in the direct message.
Oh, okay. Then before we log off. Is there any way to save the chat, ladies, and get that or no?
I can send you the chat log.
Perfect. Thank you. Thank you so much.
I don't know if it captures, it's not going to capture the private messages though.
Oh, okay. So I will find that. I don't know how. Hold on. All right. Well, I hope everybody enjoyed that, learned from it. And
yes, that was very informative, very grateful for your expertise and especially for being able to share from your lived experience as well. I'm just really grateful to have you as a partner and have you leading this training for us today.
Yeah. Thank you so much, Carolina, and all the work that you're doing to make this happen for our community.
Hello,
Awesome.
can I say something?
Hi, Joanne.
Oh, stop it, girl. I just I just love this presentation. I'm so glad that I was a part of it. And you rock. You really
Aw,
do. And
thank
if you
you.
need anything, you got my email because sent me a couple of things.
Uh-huh.
But
Yep.
I'll respond back from now on. I love you.
Okay, love you too, Joanne. Thank
You
you.
take care. Bye-bye.
Bye. We went through peer training together. So I see a hand up. Jamie?
Yeah, mine will be really quick.
Sure.
With registering with this, will we I want to follow the efforts and whatever that will be helpful. So will we automatically be in that updates with you, or do we need to do something different?
Well, I'm going to be speaking with Cal Voices because this is something that I've been culminating also with them, and I want to see kind of what direction we're going to go with, or if any of that has changed. So I don't have an answer for you, but perhaps if it's allowed, anybody that showed up to this training, and this will be up to Cal Voices, if I am able to have that contact information for updates. I'm not sure how we would do this.
Yeah, I believe we can share the registration list with you.
Perfect.
All right.
That would work.
Sweet. All right. Thank you so much. This is great.
Absolutely. Thank you, Jamie. There's another hand up by an 818 number.
Hello, can you hear me good?
Yes.
Oh, hello everyone. My name is Maria Skelton. I was logged in, but I had computer issues, so I logged out to call in. I just wanted to say this was amazing. A whole lot of great information, and I'm just so glad, like others, that I was able to attend this. Please keep my email on any email list that you have, because I would be willing to attend any other classes. And once again, thank you so much. And sorry, I had internet issues, but I didn't want to miss anything, so I just called in.
Thank you so much for hanging in there. Appreciate it.
Okay, bye-bye.
Bye. All right. I think that is all.
All right, thanks everyone for being here. We'll have this posted on YouTube in the next few days if you'd like to check out the recording and revisit anything.
Thank you all.
Thanks, everybody. Bye.
Bye.
Bye.